Good morning. This is a joint hearing between Senate Health and Welfare and House Healthcare. It's February 5th, hard to believe, and we're in a bit of a celebration today because this is the first time that Room 11 has been available to us since it was, since the renovation's been going on in the State House. So welcome, everyone. It feels good to be here instead of walking across the way to the pavilion building. This morning we've got two really important and informative folks with us, Elliot Fisher and Chris Kohler, and I'm going to let them introduce themselves in just a minute. Before we do that, first on the agenda is for us to introduce ourselves, and then Representative Black and I will make a short comment, and then we'll begin the meeting. So we'll start over here with you, Senator.
Senator Larry Hart from Orange County.
Sam Douglas from Orleans County.
Alan DeMar, Enosburg, and Montgomery.
Woody Page.
Topper McFarland from Barrytown, represent Barrytown and Williamstown.
And I'm Alyssa Black, and I represent Essex Town.
Ginny Lyons, Chittenden Southeast, Senator.
Senator Martine LaRocque-Ulick. I live in Burlington and represent Chittenden Central.
Leslie Goldman, Wyndham 3, which is Bellas Falls area.
Representative Mari Cordes. I represent Lincoln, Bristol, Moncton, and Starksboro.
And Representative Lori Houghton, I represent Essex Junction.
Wendy Gritchlow, I represent Colchester.
So good morning, everyone. We've been looking at, both committees have been looking at the work that we've done on Act 167, which is going on now since 2022, and very excited about that work. At the same time, we're very concerned about the crisis that we face in our healthcare world, in particular the cost of healthcare. And so we've started taking testimony, each of us, each committee, on the cost of care and the regulatory environment that we need in order to reduce those costs. We heard yesterday, our committee heard yesterday from the Green Mountain Care Board and the Agency of Human Services, and we'll continue taking testimony from folks who can help us with our own in-state solution. However, it's really very important that we learn from what other states are doing, and we also hear about the regulatory environment that we face and what we might do here that will improve outcomes for the state in terms of cost, quality, and access. So I've invited, it's not doctor, Chris Kohler, Mr. Chris Kohler from the Millback Bank Memorial Fund, who I think many of you are familiar with and do a great deal of work in informing us about healthcare issues overall, to talk with us about what other states are doing, and then someone you may be more familiar with, Elliot Fisher, Dr. Elliot Fisher from Dartmouth, to speak with us about some of the issues that we're facing in healthcare policy. So I'm going to let Alyssa say a few things, and then we'll work together to listen to folks who are here with us.
Yeah, and I want to thank Chair Lyons for facilitating this and frankly coming up with the idea. We've been taking testimony for 3 weeks now, sort of from individual pieces within our healthcare system and the crisis that we're facing, and I'm really looking forward today to have sort of a perspective looking at the whole system of care and also looking to other states, to see what they're doing and getting ideas for how we can put this all together and work all together and deal with the crisis that we seem to be in.
So thank you. So good. And I do want to introduce David Merman, Green Mountain Care Board member, who is here, and also Brendan Krause, who is here from AHS, the Director of Healthcare Reform in AHS, who we'll see how it goes. Maybe offer some comments or join in with conversation. My goal today, I think our goal today, is to listen and hear what you folks have to say. And then we'll have some time for questions. I think there's sufficient time for all of us to engage and ask questions for clarification and additional information. Not going down any rabbit holes, but definitely filling some gaps for ourselves. Welcome, Dr. Fisher. I think you're due. Why don't you both introduce yourselves? And are you going to coordinate together, or one and then the other?
We've seen each other's slides.
All right.
About there.
All right. So why don't you introduce yourselves for the record?
Go ahead.
So, hi, I'm Elliot Fisher. I live in Norwich, even in spite of my 603 cell phone number, which I'm embarrassed by. But I moved to Vermont 40 years ago to become a primary care physician at the VA after training in health policy and speak up.
Thank you.
Excellent. Can I ask the same of you? Because my hearing aids are never perfect. So, thank you. And anyone else, if I don't speak loudly, just raise your hand or interrupt me. So, I'm Elliot Fisher, practiced primary care at the VA for 20 years, but a lot of my life has been focused on understanding the causes and consequences of variations in poor health system performance and what we can do about it. My formal title is Professor of Health Policy, Community and Family Medicine and Medicine at Dartmouth. And I think that's sufficient.
And I'm Chris Kohler. I'm president of the Millbank Memorial Fund. I'll talk a little bit about the fund in a bit. Given what Elliot's saying, I'm a resident of Rhode Island, but a frequent visitor in Vermont. I'll talk about that in a little bit. And my own background is I've been president of the fund for 12 years. Before that, I was the health insurance commissioner in Rhode Island, so I regulated.
Put another microphone in real quick.
Sure.
Oh, give me 1 second.
You want me to talk while he's installing, or should I
You
wait?
could wait.
Okay.
And this is good because are we being amplified or not, so that we should speak so everyone everyone here can hear us?
I don't think you're
know?
being amplified, you're being recorded.
Be recorded, so we should
Can you
really,
hear
we should speak up or
Live stream.
we'll do our best.
outdoor voice?
Outdoor.
Any teachers? We gotta use the teacher voice too.
So this is what happens when you come back to a room that's been inaccessible to us for
Yeah.
several months. Yeah.
And you've got folks online too.
Yes, we do.
And we're all prisoners of the tech anyway, so they have the real power.
Let's not go there today.
Waiting for it to turn.
Just ignore the red beeping.
Okay,
Are we good to go?
thank you.
Thank you very much.
All right, thank you.
So I was saying, prior to being president of the fund, I was the health insurance commissioner in Rhode Island, regulated commercial health insurance Rhode Island to a different set of standards than normal insurance. Your colleagues in Rhode Island actually gave health insurance regulation a different set of standards, somewhat like what you've done with the Green Mountain Care Board. Before that, I ran a health plan started by community health centers in Rhode Island focused on the Medicaid population, so in Medicaid managed care. Not a clinician, have worked with staff model HMOs, big fan of primary care, and the rest of it can wait for the presentation. Thank you.
Thank you.
Well, first, let me thank the committee and your chairs for inviting me to come. I really, the opportunity to try to help us all rethink clearly healthcare, especially at this moment of crisis in Vermont, which we all are pretty familiar with. So why don't we just get going. I'm comfortable if the chairs are with my being interrupted. If you have a clarification question, besides the fact that I'm not speaking loudly enough. So I welcome interruption and feedback if it's for clarification. I think big questions about what does this mean for the future of healthcare, those I would encourage. I assume we'll come back to those questions when it works for you.
And Ellie and I have shared our slides beforehand. I would suggest that the broad conversation happen after both of us present.
Yeah.
The questions are great with the presentation, but they fit together, and so we might.
So let's make this a decision. If you have a question of clarification, you don't understand something, or there's an acronym, or there's something else you'd like to know about, ask a question of clarification during the presentation, and then we'll hold off until we've heard the whole thing. So it will fit together, as we've been told.
Yeah,
Okay,
thank you.
good. Thank you.
We hope.
Yes, we hope.
All right, here is the gist of the argument that I'll be making. I don't need to emphasize the first one. We have a crisis of affordability and access in Vermont. I think it's fair to say that the largest driver is the Vermont hospital inefficiency and our weaknesses in primary care. I think from looking at the data that there's at least $150 million on the table that could be saved within a year. And the savings in the longer term, I'll share my research and others, I think it's 25 to 50% of all healthcare spending. And I'm known to be an optimist, so take that with a grain of salt. To make progress, however, and I'll spend some time on this, we need to address the deeper causes, and I'll explain these later. I think the goal is competition where possible, regulation where necessary, and getting the incentives right so that people self-regulate toward improving health, improving care, and lowering costs. And I think my argument will sit in the middle there, that to be able to do that, we need strong, effective, and aligned state agencies and healthcare organizations who actually deliver the care to achieve, because the real aim is off further to the right, better health, better care, lower costs. And I think Vermont is well positioned to be a national model, although right now I think we're not a national model that's not, we can't be terribly proud of, since we all know this graph. One of the things I think is so important is trust. And some of you may have seen an earlier version of this graph that I did with silver benchmark plans, where the right-hand side, Vermont, looked like a rocket going into space. This is a much more accurate reflection of what's actually happened to average costs, because that accelerated graph of costs for the benchmark silver premiums was based on some things we did to draw down more money from the federal government. But this graph applies to everything we know about other sources of judging the cost of healthcare in Vermont. Notable things, Maine, New Hampshire, and the rest of the United States are all doing much, much better than we are. And we are an old state, but we're not as old as Maine or New Hampshire. And these are just some public comments from 167, which you are all familiar with. We all are concerned about hospital sustainability after the report from 167 and national data that points to the challenges facing rural hospitals in the United States. We have 4 that are at high risk of closure in this state. And the financial threats to all of the hospitals are real as their margins decline, their bond ratings are threatened. And so in the Hammery report, if you look out further, nobody looks very good on the current trajectory. None of our hospitals look very good in terms of financial performance. Hearing okay? Loud enough?
Yes, thank you.
Doing great.
And primary care is in crisis. Based on some recent analyses, 100 million Americans lack adequate access to local primary care, and we hear that from residents of Vermont. There was a very interesting United Healthcare report from a couple of years ago. It's not peer-reviewed, but they looked at nationally representative claims data, found 27 million emergency room visits among commercially insured. Actually, I don't know. It could be all payer. It could include Medicare, but 27 million. No, those are commercial patients. The average cost of those visits was $2,000. They thought 2/3 of those could have been cared for in either an urgent care center or in primary care at a national potential savings of $32 billion. It would gradually mount up if we could achieve those savings. In Vermont, if you assume the 84,000 visits that I've heard quoted, correction maybe from David, that it could be 67,000. But if you assume the potential savings, and for example, we set up an urgent care center next to the emergency room, we might be able to take out $100 million in saving by improving primary care access in Vermont. How to do that? Thank God Chris is here. He's going to tell you how to do that. Oops, I didn't delete. I've got most of these in bills, but I didn't delete the one that I had there originally. So anyway, you know, we know hospitals make up more than half of the spending in Vermont. And we've seen increasing commercial prices compared to peers. This is UVM over the period between 2015-17 and 2020 to 22. You know, while other academic medical centers, in New England, are delivering care substantially less expensively to our residents to people who are under commercial plans. And they've been going down. We have been increasing. So why that is a topic of discussion, but we've had increasing commercial costs. When you look at other sources of data, and it's not just for UVM Medical Center, although I know that's been the focus of public attention, but analyses suggest that all of our major hospitals, not excluding the critical access hospitals, have substantial opportunities to improve their cost performance. If you look back 10 years, there's this complicated measure, of the ratio of costs covered by Medicare payments, which lets you say, if you're at 100%, that's good because your costs are the same as your price, as what you're charging. You can break even on Medicare. We've fallen behind nationally, for both UVM and the non-critical access hospitals. So we're now losing 27 cents on every dollar, but that's because of our high costs compared to what we could be doing if we were mirroring other high-performing health systems. So there's a cost efficiency challenge that our hospitals have that we should be figuring out how to help them with. This is just data for UVM Medical Center, but it raises concerns that we may not be being as efficient as we can when we're working as clinicians in terms of how we're spending our time. We know that 36%, or from the data I've seen, 36% of specialties are in the bottom quartile of productivity, how much work they do when they're on the clinical time. But 80% of the specialties at UVM Medical Center are in the bottom half. Question?
May I?
Yeah,
clarifying
please.
question. When you're speaking about productivity, are we talking about like amount of time they're seeing patients?
Yes.
Or, okay.
I understand it's supposed to be measured that way. FTE, clinical FTE.
Okay.
Against how many RVU, how much revenue you generate, which is an awful way to judge physicians. I'd rather have them measured on health outcomes, but it is how they're spending their time with their patients and how active they are as clinicians within their specialty. Surgeons, most of their RVUs are doing surgery, and we know their waiting times. Yeah. So yes.
On a similar note, advanced practice nurses often don't get reimbursed the same as physicians. So when you're counting productivity and using revenue, have you taken that into account?
That's a great question. You may know the answer. Chris may know the answer, but I think and clinician or health systems folks can correct me, when this productivity, the units is not dollars. Where advanced practitioners get paid less is what they call the conversion factor, the dollars per unit. And Medicare pays advanced practitioners less per unit. So when we say that advanced practitioners are reimbursed less, it's because that technical term conversion rate, but the unit is less. I believe this comparison is for the relative value
Yes,
units.
exactly.
Okay.
Which would be the same if delivered, if
Yes.
that's for that CPT code, if delivered by a nurse
Okay.
or by a clinician.
And great sympathy for legislators who have to learn about relative value units to do their work.
We'll leave that to the regulators. No. So Representative Chena has a question. He's on Zoom. So Representative Chena, go ahead.
Thank you. Is paperwork considered productivity and administrative duty?
It probably, if it's on your clinical time, that's going to be counted against you because you don't get any points for that, and it's wasting clinical time.
Oh, hold on a second. So you're saying, like, when we say in this, in these numbers here, that time spent on paperwork is not being considered productivity?
No, it would be, it doesn't, because you can't bill for paperwork, you don't get credit for paperwork as part of your productivity. So paperwork distracts you and keeps you away from doing the work of patient care itself, which would generate a claim for seeing the time you spent with the patient.
Thank you for clarifying that, because honestly, as a healthcare worker, when I saw this, my heart dropped, and I was like, how are we wasting our time? But if you're counting paperwork as not productivity, it makes a lot of sense.
Yeah, how can you be productive when you're consumed in a system that's about documentation? Great question.
I was just wondering, are these numbers compared in the quartile to equivalent academic medical centers, or, I mean, I'm assuming,
I think
if in
so.
an
This is
academic setting,
Chris
you're
Whaley.
dealing with residents and,
I'm trying to remember the spreadsheet I looked at. I think it is almost all academic medical centers.
okay, thank you.
But I may be wrong on that, and this is older data. Chris Whaley could be asked to give an update on the data and whether it's improved. I'll plug along.
This is a, if
Like
I can,
one more question?
Sure.
this is a basic clarification. Not everyone knows that Mary Hitchcock is Dartmouth.
Oh, yeah, that's a good point.
Yeah, so
That's-
just
that-
so the room knows.
That's the way it's labeled, and those numbers are actually percentages, so 317 equals 317% of Medicare, which means 3.17 times what Medicare's price would be. Is that? That's a really, thank you for asking those questions. That's a really important clarifying question.
And since we're going, it's worth noting that whether it's 165 at Tufts or 317 at UVM, the same service is being reimbursed at 1.5 to 3 times more when it is provided to a patient who is commercially insured. So employers, not just insurers, employers are paying 3 times what the federal government is paying for the same service.
And we'll come to actually the next, I think the next bullet. You know, the Vermont Healthcare 911 analysis that came out on the white paper last year was that if UVM adopted the cost efficiency of its peer academic medical centers, the savings would be $170 million. And this is just for administrative costs. This is not clinical administrative costs. This is what they refer to as the higher level network and administrative. There's a bucket that is just administrative costs, not even administering a clinical program. Like cardiology administrative costs would not be included in the general administrative costs. And as I'll show in the next slide, I think if we started to bring everyone together toward a goal of improving health and lowering costs, we could do much better. We could reduce, I'll show you that data in a sec, right now, in fact. So, you know, the reason I ended up being on the road starting 25 years ago was we showed that about, you know, if we could get everyone to practice like the pale green areas there, we would save 20% of Medicare spending. And it's mostly for discretionary utilization. It's how much time people spend in the hospital where they would not be spending time in the lower spending regions, in the pale green regions, and how many specialists they see and how much time they're spending visiting physicians. And there were no differences in outcomes or quality across the different regions of different spending. When the academic medical centers got angry at us, we repeated that analysis, comparing the best medical centers in the country, the top 100 that they thought we should look at. We found exactly the same thing. So across academic medical centers, the lowest cost centers, which included, you know, in terms of measured as utilization, so not ignoring prices, we standardized everything. The lowest cost academic medical centers were doing it for 30, 40% less than the higher cost centers. And the outcomes were equal across these academic. So there's real opportunity to improve performance. It's also, that analysis ignored pricing differences, and we're all familiar with the important role that pricing, differences in pricing make, because some hospitals can charge higher prices than others. So it's about 50-50. Prices explain half of the difference. Utilization, unnecessary utilization explains about half of the difference. So if we want to make healthcare better, we have to pay attention to both. And then, you know, this is, I think, a very important article. I'll walk you through some of the work from Intermountain Healthcare. This is an article by Brent James and his colleague Paulson's first name is missing, but they argue that we could achieve dramatic savings. You know, the estimate from this article is that they could reduce at Intermountain Healthcare, they expected to be able to reduce costs by 50% if they were under a full capitation model where they could take advantage of the savings from all payers to invest in the work to keep people healthy, improve the quality of care, and do the administrative work to take costs out at every opportunity. So just a couple of case studies from them. So this is what they did over about a 2.5-year period. It's not even quite 2 years. They were trying to figure out how to improve the efficiency of hip replacement, the most common surgical procedure that's done in the major surgical procedure that's done, especially in the Medicare population. It's a great procedure. Are there any orthopedic surgeons wearing white coats over there? I can't remember which one of my hips.
I should have introduced them earlier, but they are residents from the University of Vermont Medical School.
Oh, great.
In OBGYN. And
Back
we're
to you
happy to have them here.
Back to you in a second. So it's an amazing procedure. And if you want to pay attention to reducing the cost of doing it, it is possible. How many people are unfamiliar with that little spinning wheel at the bottom? That is a plan, do, check, act cycle that people in quality improvement do religiously to figure out what is the thing we should test next in order to reduce the cost. So the first rotation of that would say, let's try this. Let's try, I'll make something up. Let's try to see if we can reduce the administrative costs associated with admitting the patient and discharging the patient. So that could be the first cycle. That could be pretty easy to do. It's less paperwork, automatic, whatever it is. First cycle, spin, you plan to do it, you do it, you test what you evaluate what you learn, and then you go back and say, did that work? Do we want to scale it? What's the next thing we want to test? And that would be another improvement cycle. This was all taught to us by Don Berwick when he brought modern improvement science from industry into healthcare about 30 years ago. This is the one system back in the 80s and 90s that was doing an outstanding job of introducing this across the whole system of care. That's what Brent James was doing. Here's another example. Cardiac procedures that are needed to be done in a cardiac cath lab, probably one of the most expensive inpatient services we have, also one of the most profitable. This shows the rate of cardiac catheterization over a several-year period. Where they started to lower the rate, it was when a guy named Don LePay, who was head of cardiology, said, let's get rid of inappropriate cardiac caths, inappropriate procedures. There was a lot of excitement about the high rate of inappropriate cardiac catheterization and related procedures in those years. And they said, let's do something about it. They reduced, with a simple checklist that Don LePay introduced in order to get your patient into the cath lab, support at the point of care, made it easy for the docs, took care of prior authorization. So doing the checklist, he got the plans all to agree that this was prior authorization. They didn't need to spend hours on the phone. And they reduced the rate of inappropriate procedures by 24%. They lost money, of course, as a hospital. Luckily, yes, please, sorry.
Cardiac nurse here.
Yeah.
Was there an analysis of, were there cases that were missed because it was determined that going to the cath lab would be inappropriate?
So
like thinking about women who typically present with these
yes,
symptoms.
that's it. The only thing they had in the input file was what the doctors wanted to get done so the application was the physicians, and if the physicians wanted to override the checklist, they were free to. They could just say, this is important, I'm doing it. I do not think they were looking at that time for all the people not yet seen, evaluated sufficiently to manage their heart disease. And I'm sure there were missed opportunities to improve medications, improve blood pressure control, improve treatment, and maybe some people who should also have gotten cardiac cath. Great question.
1989. It was a while ago.
Sorry?
1989.
It was a while ago.
Yeah.
I'm sure we weren't paying any attention to women then. They weren't even in NIH trials. I come from a family of 4 other women, so.
We've been sensitized.
Sorry?
We've been sensitized.
Not adequately, they would tell me. So, this is, I think, a really important story. It's a long time ago. It's sort of a parable of American healthcare, and I'll mention briefly some other places that are more modern. Charles Sorensen established a goal of keeping care affordable for the whole system, aiming to hit the consumer price index plus 1%. Really remarkable goal. It's not what we've seen in Vermont in the last 10 years. And his strategy was to improve care and eliminate waste. They did have their own health plan, Select Health, for which, if they improved care, the plan saved all of the money between what was expected, what the revenue that was paid, and what they were spending. So they had a powerful incentive, but that was sufficient to cover the full costs of the initiative. So what you see is what they achieved, which is about, it's in a different version of this slide, $700 million on a $5 billion. It's someone, where are those residents who got calculators in their pockets? Anyway, there were big savings achieved over the period where this happened. And they had the highest bond ratings of any nonprofit in the country at the end of that period. Because what you want as a hospital is solid finances, good margins, that gets you a good bond rating, and that lowers your costs of borrowing. And it's possible. So I just gave you examples of what happens at a practice level if we get clinical practices, whether primary care practices or cardiology practices or orthopedic practices, to improve care. You can both save and improve outcomes. The outcomes in the cardiac cath lab were better. When you do it at a hospital or health system level, you can do it. But I've now tried for 35 years to slow the growth of healthcare spending in the United States, and I've obviously failed. We have not slowed it one whit. And so I've recently stepped back to try to understand what have we been missing. And I think there are two pieces of that. The first is market failure. You know, healthcare is rife with market failure. Whether it's about how patients make decisions because they're told to get things by their clinicians, that's an issue of how markets work at the most basic level. But it's also challenged by monopolies. And right now in US healthcare, 90% of markets are too concentrated for robust competition at the hospital level, which means they can do what we've seen happen in Vermont, rapid escalation of prices. Allowing hospitals not to be in competitive markets leads to other things as well. They can be inefficient. They can ignore quality. The data on the quality of care in markets that are not competitive is not encouraging. Quality is actually worse in uncompetitive markets because they don't have to compete on quality. And, you know, they can allocate resources without regard to their public missions. So there's a second problem, which I want to blow up a slide to have you look at, which, you know, I label the balloon problem. These are just some of the ways that in a healthcare system, when we try to squeeze in one place on the balloon, those who are on the other side can push out in some other place. You know, and whether it's public payers controlling prices, we think you should live within your costs. Oh, we can raise our prices to others. Bundled payments, you know, they're a very important way of perhaps improving care, but it's very easy to shift costs out of the bundle, and so bill commercial payers and Medicare twice for the bundle. So you shift the expensive tests outside the bundle that you were previously going to be paid for and get paid twice for them. ACOs, which some of you may know, I spent 4 years in Washington trying to figure out how to get them to be launched. And everyone in Vermont now hates it. Raise your hand if you hate ACOs.
Not agree.
All right. Our public advocate is raising his hand. This is terrible. But the challenge with ACOs is you can use them to keep some of your patients out of the hospital and then fill those beds with higher paying commercial patients. And so there is evidence that for the patients in the ACO, if the ACO is run by primary care physicians or physicians and not owned by hospitals, they can reduce costs and improve care. But the evidence on hospital-owned ACOs, maybe we see that in Vermont, I'm not sure. I don't think the people in the, so, and you know, if you limit plan profitability, well, you just raise premiums or offer a shift to offer low-value plans, et cetera. The worst one is our effort to increase high-deductible health plans, which just shifts costs to consumers and leads them to make poor decisions before they've hit their deductible. The data's pretty good on this. You skip the stuff you need if you're going to have to pay the full cost. And then once you get the deductible, who cares? You're going to get everything whether you need it or not. So I think states, and this is a paper that Chris was kind enough to agree to help with, we tried to look back at what explains our failure and where might we look for ways to make things better. And we landed on this notion that it is about effective state agencies charged and resourced to improve health and care. States have actually more authority. The feds can't intervene and do this all down here. We are the ones who can do this. And you'll notice that off on the left-hand side there, I've had this idea, which is increasingly talked about, and this is, remember, I'm now talking at the policy level, a learning healthcare system where our aim is affordable, accessible, high-quality care and better health, and then we use that improvement model to measure what we need to measure, evaluate, plan, and then implement the things that we think are going to make a big difference and make sure we see how we did, so we can change course, adjust it, and move on. And that's I think what, my pitch would be, is basically at the theory level. Luckily, Chris gets to tell you how to actually do it. We need better data, and we need transparent evaluation. We need to know, I think everyone's curious about what is the cost data from our hospitals. We're all in the public confused about who's right or wrong, the Green Mountain Care Board or UVM. Let's just get a level playing field and have some audited financial data that's using the same system of accounts, and we can all understand where the efficiencies are and the inefficiencies are within our hospital system, and then use that to evaluate what's going on and make suggestions about what to improve. We need real-time quality measures. That's a different topic than today. But we need it at both the clinical practice level, as I think I suggested in those initial slides, the hospital and the practice, but we also need it at the larger level of the health systems and the regions where you guys are responsible for helping us get better. Use the data to identify drivers of poor performance. The article is actually pretty readable, and I know that we can make it available if anyone. It's only 1,200 words. That's why it doesn't make any sense, because it's too simple. But Chris let us publish a working paper on his site that goes into many more of the details about the argument. So I'm also happy to take follow-up calls from anybody. And then, there's a term in medicine called turfing. So any calls I'm welcome to take, but I'll turf them to my colleagues. When a resident is trying to give someone else a job to the intern, they turf it to the intern or to their chair, whoever. So the second idea, strengthen planning and implementation. That's for everybody. I think we need a state strategic plan for health and healthcare. I think we want to align hospital strategic plans towards system transformation. I think it's almost, and I hadn't really thought about this until getting ready for this work this last month, that we let hospitals develop their own strategic plan. Well, how on earth is that a good idea? Shouldn't it be aligned with what we're trying to do? They're nonprofit institutions. Shouldn't we get to give them feedback on their plan, not just the people who are on their boards, but their communities and the state as a whole, or an evaluation and planning unit? Question, yes. Sorry, thank you.
Do you have any states in mind that do have been able to, that are stronger, that have a state?
This is his. I'm gonna leave all the questions hanging. And Chris is gonna.
That's the question that waits till after they both presented, but it's a good question.
It's a great question.
If I could ask, did you say this article would be available to us? That you give us a link to this article?
Oh, certainly.
That would be wonderful.
If I have given it to Kiki, but I can certainly have that and the link to the link to the Millbank site.
Great.
Kiki, can you help me remember to get those to the members of the committee? And then the third thing is, we need all payer oversight, payment reform, and regulation. It's nuts. I'm sorry, that's a technical term. It is nuts to ask a practicing clinician or an office-based practice to deal with 20 different health plans, to deal with 20 different sets of incentives. The reasons ACOs failed or aren't living up to their potential is that you're under an ACO for one, but you're still under fee-for-service. 70% of physician revenues in the United States are still fee-for-service. Yeah.
So I'm going to ask a question there. So the hospital health plan is one thing, its strategic plan is one thing, but then commercial insurers are also doing the same thing. So how do we?
Great addition. We should have them, but there's another bullet that needs to go on here that says, engage our health plans in strategic planning around what we need. And of course it should have primary care or community-based health plans, health systems that are, all of us should be part of the same goal, have the same aim, and then figure out how we're going to do the work together to get it done. I'm sure Mr. Foster will be happy to take all those responsibilities on. We'll talk about that when he's here. Question? Are you okay?
Yeah.
Okay. So I think there are the reasons to do this is the market failure and the balloon problem. And unless you get your hands around both of those to create competitive markets where possible. And I think we can have academic medical centers competing with other academic medical centers in some other place to show how they're doing on the metrics that we want them to perform well for. I firmly believe in competition choice. And then we need someone to set the table that makes that possible. The last thing, of course, you need to do is measure impact. So just a few concluding thoughts. We all are hopeful, and many of us are, that the AHEAD model will be successful and bring great resources and capabilities to the state, but I don't think we can have confidence in that happening. So with or without AHEAD, and we can't afford to wait 3 years to start controlling healthcare costs, right? So with or without AHEAD, we need to do something. And I wrote this sentence before I heard that the governor's budget includes some bridge funding for primary care and SASH. I'm not sure it's sufficient. We may need additional investments. I already suggested that if we invested now something in primary care, we might get real savings from the hospital in the pretty near term. So I think the questions are, can we start now to advance better pricing and volume controls on the hospitals? Advancing the notion of a global budget in quotes, that is, what should they be spending and how we get them to live within that budget. Build now on existing strengths that we have in the state in quality improvement and primary care, and then prioritize high impact initiatives. The most expensive service delivered at Intermountain Healthcare was pregnancy and newborn care. That service line, that was the first thing they prioritized in terms of investment in order to keep kids in utero, in the womb for as long as possible, and then take great care of the moms and the kids so they get a great start. It was a profoundly impactful, we still have our OB residents here. So it's where to start in the improvement. I don't see why any delay in starting the improvement work has to wait for you guys to pass a bill. Maybe it's the bully pulpit, so I'm really excited that you're so interested in this, and I know I've spoken too long. Over to Chris.
No, you haven't. This has really been extremely helpful.
Yeah.
Can you, on the bullet administrative and other costs, can you again go into detail about what you're looking at, what you're calling administrative?
Let me look at my slide here. Oh, back a slide.
No, it's go forward. That one.
Oh, administrative and other costs. I think it looked as though the lowest hanging fruit is the category of spending that falls under administration and general services, I think is the name. But you should, Tom Reese is knowledgeable and was the one who did most of those calculations. Similar data comes from different consultants that the board used last summer. But that is, and actually this is not a bad moment to tell one more story because you've reminded me. So, there are other hospitals in the country trying to live under their Medicare costs, within their, break even on Medicare. One of those, I understand that Tom Walsh, who's a board member, has reached out to Peter Pronovost, who's leading their care transformation, and he has agreed to come talk in Vermont. What the public data about Pronovost's work and University of Cleveland Medical Center's work was that in 1 year they took out $250 million in administrative costs. In 1 year.
So I have a bill that gets at reducing executive compensation.
Oh, you introduced it?
Yes.
Great.
Is that,
great topic of conversation.
Is that in that bullet?
I think great question to ask Peter. I think Peter Pronovost, when he comes, I think the tension we face right now in American healthcare is that this is a really hard job, especially now if you add that you want, rather than just increase your revenues, you're going to have Elliott tell them that they should be improving quality as well. It's a very competitive market to recruit the kind of capable leaders that can do that work, and I bet Chris will have something to say. So I don't know what the right number is. I thought it was I didn't think that the compensation we saw is representative of the kind, this year, is representative of the kind of that I saw in the leaders I've spoken to at Intermountain Healthcare who took reasonable compensation, but nothing like the compensation that was received here. So it's a good topic of conversation. I don't know what the right answer is.
Peter Provost.
Provost. You can ask him about the hard question. Oh, you can ask him what he's paid. Oh.
So I think you indicated that he was being invited by Tom Walsh
Yes.
into the Green Mountain Care Board. So one of the fine lines that we walk in this building is becoming the regulatory entity versus
Yeah.
giving the umbrella policy to the regulatory entity. So those are the conversations that we're going to have. When he's invited and goes into the board, that'll be an opportunity for us to hear and understand where the line exists for us. And I think that's important for all of us to understand. I think we see the media reports, we read all the details, we understand that there are things that need to happen. Yet some of those things that need to happen should happen at the board.
Absolutely.
And what we can do is to give the board the authority and the enthusiasm and the platform to move forward. So I want us to be very careful in here that we don't step into that regulatory thought process. Although all of the information that you presented, or a lot of it, takes us in that direction, but it helps us to understand what we can do, what our role might be in this, and that's
Direction setting.
going over.
Yeah.
And if I may, I'll talk a little bit about this. Senator Lyons, I think that's an excellent point. I think the other thing you can offer is accountability.
Yes, you're absolutely right.
Bring to this table to be accountable to you. I mean, as someone who's been in the executive branch and has been lectured by legislators to say, you're doing policy making, that's my job.
Right.
It's not an easy line,
No.
but the way to figure out that is accountability. It's to make sure that that you are holding the entities that you've given statutory authority to accountable for some objective outcomes around how are we doing on these things we told you to do.
Thank you. You're absolutely right. The combination is dynamite.
And part of the reason for my presentation was to lay out dimensions of things that I want you to think about holding others accountable for. Because I think accountable for improvement. We want to see continuous improvement. We want to see an annual progress toward lower costs and better care. Great. I'm done. Over to you.
Okay, the first test is the technology.
Can I just make?
Yes, David Berman.
Yeah, David Berman from Green Mountain Care Board. I'll speak a little bit. But Peter Provost is going to be presenting to the board on March 5th, I believe.
Oh, great.
Excellent. March
at
5th.
1 p.m.
And it's before crossover for us. That's a good thing. It's also during the week that we're off. That's a bad thing. But we'll be able to zoom into that, I would think.
Yes.
Or at least look at the recording of it.
Yes, and if you zoom in, there'll be plenty of opportunity for questions in the public comment period at the end. You guys aren't usually the public, but in the context of a board meeting, it's a great opportunity.
Thank you. Can you ensure that we get that information sort of
Yes.
sent to us? Thank
Yes.
you. You can send it to Kiki and is it Lori. Who's your? Kristen, sorry, Kristen. Kristen's new, but if we send it, we'll get it. Thank you. One question.
I'm interested in accountability because people come and they give all their data and then they sit there and then what? So I don't know, once we think about accountability, what's the next steps? And maybe you're going to talk about that, but yeah. So thank you.
Did you want to comment on that or?
No, I was looking to you.
Great,
Did you
we'll
want to hold that till afterwards or?
Yes, great question. I think it's kind of teed up. It's a really important one that we can talk about as a follow-up to this. So may I Proceed. Okay. Thank you very much for the chance to speak with you all. I think, well, here's what I'd like to talk about today, just to make sure you understand. Millbank, revisit the notion of a problem, particularly you folks as policymakers, talk about some barriers to state health reform. I was asked specifically to speak about policies to address rising commercial prices, and then step back a little bit and think from Vermont. It's important if you're sort of thinking about roles and responsibilities. I don't bring anywhere near the technical expertise that Dr. Fisher brings. I'm not a clinician. I have the scars, though, of working on this, particularly from the executive branch side. And then we at Millbank have the real privilege of working with state policymakers such as yourself. So we try to have a sense of what's going on in other states. So that's the sort of the perspective that I bring to this. The Millbank Memorial Fund this is our mission statement. We work to improve population health and health equity by collaborating with leaders and decision makers and connecting them with evidence and we're connecting with experience and sound evidence. We really focus at the state level as opposed to the federal level because we think states are where the action is. As Dr. Fisher was saying, frankly, it is where we have experience. And we like working with you guys. You know, we have a lot of respect, appreciation, support for public service. You guys could all find easier ways to spend your time, and we appreciate the commitment that you make to doing this, and our role is to help you do a better job with it. We have 3 particular program areas. That's what these bullets are. We do a lot of state health policy leadership development. We work with folks in both the executive branch and the legislative branch here in Vermont. We work on particular issues, notably primary care and sustainable healthcare costs or affordability. I think that's what brings us to the table here. And then we publish. We publish the Millbank Quarterly, a peer-reviewed journal, as well as papers to support our work. In a side gig, I have taught U.S. health policy, and when I sit with public health students, I say the important thing is, really important thing when you're thinking about policy is say, what's the problem that we're addressing? And it's really hard with healthcare because it is 1/5 of the economy. And so you ask 20 people what the problem is in healthcare, you're going to get 20 different answers. Is it a notion of, sorry, I can't figure out how to turn off my alerts. Is it a notion of affordability? And if it is affordability, whose affordability? Because a Medicaid agency, a state budgeter is going to define affordability very differently from an employee who's looking at a high deductible. Is it access to services? Is it provider sustainability? We have a particular issue. We talked about rural hospitals. Health status, quality of care, differential health status. And I think it's really important as policymakers that we know what the problem is that we're taking on. Dr. Fisher has made a strong case, and I would support it, that in Vermont, we have a particular problem with the rising costs of commercial insurance driven by rising provider prices, especially hospitals. That's not to take away from all the other issues that are important when we're trying to do this Rubik's Cube around patient access, around sustainability of providers. But it's our belief, and I think that's the case in Vermont, that affordability it's important. It's frankly politically important because it's what people feel, and it's a way into some of these other issues. I would note you're not alone in this problem. When we work with a number of states around looking at what is happening to healthcare costs in general, we consistently find that Medicaid and Medicare are relatively under control. The problem is commercial. And when you look at commercial, the problem is prices. It's not utilization. This is increases over time. I'm not talking absolute costs. And the increases are in commercial hospital prices and pharmacy prices. So if it's any sympathy, you're not alone in your pain. More generally, and this is what Dr. Fisher is getting at, is that in the US, we have an unbalanced healthcare delivery system. If you look at high-performing health systems like Intermountain, in the US, and if you look at other countries, you'll find that they spend a lot more on public health, a lot more on prevention, a lot more on community-based services, and a lot less on specialty care and hospital care. And that has consequences. It has consequences for public health. It has consequences for the money that's available for education, social services. You're looking at consolidation proposals, and a lot of those are driven by the district costs around healthcare. I saw the article in the Digger. And that money could better be put in people's wallets for what they spent. So there's no other no other country where healthcare consumes as much resources as they do in the US. And that's a real problem for you as policymakers, because as an economist says, the iron law of healthcare is that my expense is your revenue. These are jobs. And we talk about meds and eds economy. And so it sounds great to say we're going to take money out of healthcare, but that's somebody's job. And that's a real, it's hard. Welcome to your job as policymakers.
Do you have a
This
clarifying
may be
question?
for later, but do other countries rely on competition the way you are suggesting we should? And that may be a later question.
At a high level, no. There's much more of a, we were talking about this, we shared a car ride up from White River Junction. What would happen if you had publicly funded medical education for everybody? It would completely change the contract around what clinicians we train and where we put them. And that's publicly funded medical education is intrinsic to most of these other countries. Now, we can't wave a wand in Vermont and change that, but we know what we're navigating towards.
But maybe we come back to other country models and what, I mean, competition versus single payer and what that means, if you're curious about it.
So you saw data from Dr. Fisher. This is just another piece, actually from the same source, around Vermont's prices as a percentage of Medicare. What I've done is, in very high-tech form, I've highlighted the 6 New England states and pointed an arrow towards Vermont. This is exactly the same data source that Dr. Fisher had. It's just a different way to present it. This data is actually available at the hospital level if you want to look at it. I'm sure the folks at Green Mountain Care Board have done it, but it's just to supplement what Dr. Fisher was talking about. And again, these are, just to emphasize, these are multiples of Medicare. So we are asking employers and us employees to pay in Vermont 3 times what Medicare is paying. And the dynamic, I've seen this as this is the balloon problem that Dr. Fisher was talking about. And I've seen, I'm not going to name particular health systems, but it's economically rational behavior. I get what I get from Medicaid and Medicare, and then I get what I can from the commercials. And that is economically rational behavior for a health system. And that was what I learned as a regulator. If you don't like the way people are playing the game, you got to change the rules. You can't, my job there was a referee, and people are just playing their game. And you can't expect them not to do that. You got to, I was the referee. I had to change when I blew the whistle. Okay, so big picture, 2 barriers that states face when you're doing this work of taking this on. Dr. Fisher already said it, aligning policies between payers. Clinicians rightfully say, stop the madness. Why do I get paid 3 times the amount depending on what insurance card they're having? Why do I have to deal with different quality measures, different paperwork requirements? We had that request earlier on. Providers really want alignment, and we need alignment for system change. A bigger one, and we're going to get into this, I think, in terms of the accountability question, is how do we do the work that Dr. Fisher talked about when the market doesn't work? The market does not work in healthcare. But we like the market to work because it makes these hard decisions about allocating resources. It leaves it to the consumer. If I want to buy an old crummy car, I do that. If I can afford to buy a new car, I do that. We don't like to say that for healthcare. But then making those decisions is really hard. And how do we set up well-resourced, durable structures and processes? I'll get to this in a moment. The Green Mountain Care Board is one of the most advanced, and you may not like hearing this, It's one of the most ambitious, sophisticated ways for doing this work. I'm gonna call you Elliot because I'm so tired.
Please.
Dr. Fisher is 4 syllables, Elliot is 3.
Can I just say, we agree with you?
Yeah,
Yeah.
and think about Elliot's loop. This is just a chance to learn how to do it better. This is a chance for a process improvement around how do we do this oversight. So now specifically to policies to address rising commercial prices for hospitals. We actually just published work on this. The citation is there. I'll make sure that Kiki has it, specifically for an audience such as legislators around, okay, you got rising commercial prices. What can you do? These, I would actually think for you folks, are baby steps. You've already done this. You're ready for, I don't know, at least junior high, maybe high school in terms of our educational thing. But what I was asked to spend a little bit of time are these 3. How do you do something around reference-based pricing? How do you think about a hospital price growth cap? And then how do you review hospital revenue and/or price growth? And that leads to this discussion around global budgets. So I'm going to spend a little bit of time on these last 3 items and then try to think about how they fit into an overall structure that you folks have in place. And this is assuming, again, we prioritize the issue of rising commercial hospital prices. If we're working on something else, we need some other strategies. Drug pricing, really important. A different set of strategies, different set of policies, probably with some federal cooperation. For instance, rural hospitals, important consideration as you think about the problem that we're focusing on. So reference-based pricing, it is a hot item. A lot of folks are talking about it. Let's make sure we understand what it says. You're indexing hospital prices to percentage of Medicare. You've seen this data. Oh my gosh, 350% of Medicare, that's outrageous. Let's pick a number, 250, 175, whatever number you pick. We have experience in other states. There are some items on your policy menu. You can apply it to a narrow set of services or more comprehensive. You can exclude certain hospital types, or you can apply it to specific market segments. I'm going to give some examples. The pros are that this gets you aligned with Medicare pretty quickly. You don't have to do a whole lot of work around cost analysis or anything like that. And it's a way to address what Elliot notified or called up the hospital consolidation issue. The cons are that you could be squeezing the balloon and a health system could just say, okay, well, we're going to make it up with utilization or we're going to charge prices for the services that aren't affected. And we're not addressing the rebalancing issue. That's our real, I ask you to keep that in mind. Fundamentally, we have an out-of-balance health system. How do we build our community capacity if we want more prevention, more emphasis on social services? So what's been the experience? I just want to call up a couple other states. Montana was actually an early pioneer on this, led by the executive branch, and they did their state employee health plan. And they just told their administrator, because they're self-insured, look, you're only going to pay 220 to 225% of Medicare rates. So it wasn't a big haircut and a different rate for outpatient services. I can only find data up to 2019. It generated a lot of savings. They just they said to the administrator, look, you're going to do this with the hospitals. They didn't even wait for legislative action. In Oregon, there was a law that was passed. Again, it was focused on public employees. They set it at 200% of Medicare for in-network and 185 for, actually they did it out of network as opposed to inpatient and outpatient. That was to get the hospitals to stay in the network. Why did they pick 200 as opposed to 230? It probably was where they started. They excluded rural and critical access hospitals to sort of take them off the hook. They think that they have, a study out of Brown thinks that they have saved 4% of total planned spending. Not the silver bullet, but significant. 4% is significant. And that's a 4% reduction. That's not a reduction in trend. And they couldn't find any, hospitals just ate it. It looks like they got the cut right enough so that hospitals just took the loss. They lost in revenue. They didn't try to make up for it someplace else. It's worth noting that Oregon and Washington are now considering applying this to all commercial health insurance. As you can imagine, hospitals in Oregon and Washington are not saying, oh, thank you very much. We will voluntarily take that reduction in revenue. This is my expense is your revenue, and you can look for signs of blood from your legislative colleagues as they negotiate this out. I do want to say one thing about, sorry, I'm going to go back to this for one other comment about reference-based. Well, I said it in the pros and cons. This is a mechanism. It is, in effect, a tool or a strategy that's part of a larger plan. I think this gets to what Senator Lyons is worth you thinking about. Is this, what's the directive that you give, in your case, to Green Mountain Care Board? Do you say, go do this? Do you say, consider it and let us know what you're thinking about? It's worth thinking about what is the, if you want to investigate this or pursue this, what's your role and what's the Care Board's role? Similar, a second strategy, hospital price growth caps. This is a little bit lighter touch. This is saying to hospitals, okay, we're not going to take money from you, but we're going to limit how fast you can grow going forward. This is near and dear to me because we did this in Rhode Island. We did this through health insurance regulation. In Rhode Island, we did not have hospital budget review. We documented this sort of payment disparity and price increases over time. The health plans were coming to us with rates. They were big rates, 5, 10%, 12%. We said, what's driving it? They said, our hospital prices. We said, why can't you do anything with it? They said, my hospital, I gotta keep the hospital in the network. I can't say no to them because they dictate the price. They have the market power. So we said to health plans, as a condition of your rates, you can only give CPI +1 to the rate, to your hospitals in your rate negotiations. The health plan said, can we do that? We said, let's find out. And it stuck. So we, in Rhode Island, they've been doing this since 2010. In that time, Rhode Island has had the second largest, actually this fits well, the second largest, slowest growth in commercial premiums in the last 20 years of any state in the country. The #1 state is Utah, where Intermountain is big. So, and hospitals in Rhode Island have stayed in business. In effect, we've put them on a diet. You know, we've limited the rate at which their commercial revenues can grow. The advantages of something like this is that it's really easy to implement, relatively easy to implement and administer. And it's politically easier than taking away. Because we weren't taking money out of the hospitals, we were just limiting how fast they could grow going forward. The cons are that to the extent hospitals are paid differentially, we were health insurance regulators. We didn't have the statutory authority to do that. It doesn't build community capacity, although we did some things around trying to rebalance and put more money into primary care. It doesn't really align with Medicare as much as people would like. And you've got this big self-insured business, although we think that the self-insured beneficiaries in Rhode Island have benefited from these price increases, because it's the same administrators, Blue Cross and United and Tufts, and they just turned to the hospitals and said, you got to take it off. I'm waiting for my thank you note from Jeff Bezos and Walmart for lowering his premiums, but it hasn't come yet. The last piece.
You got a question?
Yes.
I'm wondering, has it had an impact, however, on accessibility, limited services?
So we have a number. In Rhode Island, a number of financially weak hospitals. It's unclear how weak they are, in part because we don't have. I'm going to speak as a Rhode Islander here. We don't have the insight into hospital finances that you folks do. So hospitals come and actually that we don't have for insurers. So if you ask hospitals, they would say, yeah, I'm starving. And we do have some hospitals that appear to be fragile that are talking to owners, outside owners that we would rather not. But we want to, frankly, in Rhode Island, they want to force that question. I think the next step in Rhode Island is actually financial oversight, like Elliot was talking about this, a single source of truth around hospital finances, the way we have it for insurers. We have pretty good insight into insurer expenses. We don't into hospitals. And so when hospitals come and scream bankruptcy, we have to take their word for it because the state has not funded an adequate examination oversight structure to render an independent opinion around those sorts of questions.
Another question.
I'm sorry.
What about quality in Rhode Island?
Well, from an outcome standpoint, we are, Commonwealth Fund ranks overall high-performing health systems on a balance of quality, costs, health status. We are neck and neck with Vermont right now. You know, New England states always do very well. And so although the insurance regulators don't have responsibility for it, the hospital quality statistics have not suffered as a result of these.
Not suffered.
Right. The last piece I was asked to talk about was hospital global budgets. The idea here in broad concept, and I'm at a very high level, is to set total or per capita budget for hospital services with adjustments for shifts, populations, and risk mix.
So that would happen at the Green Mountain Care Board level?
Yes.
Yes, so they would get that engaged within the services available. And then I'm gonna ask you another question, which you're probably gonna say, save it for later, I'll do that. But so within that mix, of payment mix, there may be fee-for-service, value-based payments, capitation, block grants, yes or no,
So
or is that something to look at?
That's almost a flow of funds question.
Yes.
And in I got bad news for you that when other states talk, they want to know what's going on in Vermont. And so you're sort of being looked at as pioneers around this, mostly because of the Green Mountain Care Board. I will say what they do in Maryland is they set a budget prospectively on a per capita basis. I believe, and folks at the Green Mountain Care Board can correct me, claims are paid on a fee-for-service basis, and then they reconcile at the end of the year. So the money flows, the hospital knows what they're going to get, they still got a bill, and then they reconcile at the end. It's not like there's a fork full of money handed over at the start of the year, like we do in some other budgeting models. It's important to note that Maryland's the most mature. They have had aligned payer rates between Medicare, Medicaid, and commercial for going on 40 years now because of agreement with Medicare. And they are proceeding on that. What they are doing could be construed as global budgets. You have to define what are the services that are in there. Again, to Elliot's sort of process improvement, they're continuing to iterate from a policy standpoint. The important things I would note are the next stage is their AHEAD model. So Maryland, like Vermont, is a first generation AHEAD model. There have been some changes in the federal administration. I was just talking to the folks in Maryland last week. They are proceeding full speed ahead with their AHEAD model. And so they're acting, we know this uncertain environment. How do you think about something like that? And my observation, and I don't meet with the folks at the Green Mountain Care Board, is that this for the Green Mountain Care Board would be a change in mechanism. They are already reviewing hospital budgets. And so I don't want to say it would be easy, but it's conceivable to say, okay, instead of budgeting on the way we do for school systems, what are your past expenses? We're going to do it on a per capita basis. We're going to say, what are you doing on a per head basis? So I view the idea of global budgets as a technical implementation challenge, not a conceptual challenge, because you've already said, hospitals, we're going to oversee, health systems, we're going to oversee your budget. You've already created that accountability. This is a different way to do it. And not many other states in the country could say that. You're much closer to being able to implement this than other states because of the Green Mountain Care Board. It's worth from a definitional standpoint because we all have a lot of scar tissue around accountable care organizations, whether you're an advocate for it or an implementer as you are. The focus of hospital global budgets is on existing institutions, a health system, a hospital, whoever you decide. Accountable care organizations are trying to create new organizations. That was the ambition with OneCare. It's the ambition with the Medicare ACO program. So in global budgets, you're dealing with existing institutions. I frankly think that gives you a big advantage in terms of implementing because you're not trying to create new stuff, new relationships.
So our accountable care organization obviously is going to be defunct within the next year, this year, and however, there are some attributes that come from that in terms of quality, metric, data collection, and analysis that might be helpful to the board in the work that they are doing.
Well,
that's a question.
I will get to yours in a moment, sir. I have a national expert next to me, but that won't stop me from trying an answer first, and then he can correct me. The most important thing in what you're saying, I think, is this notion of accountability for the person, the population, to say, are you taking care of the needs of the person? And if you build a global budget on a per capita basis, you are still able to have that accountability. You're able to hold the hospital accountable for quality health as well as costs for the set of services that you defined. Before I go to you, is that anything to add?
Yeah, I think it's a little trickier for hospitals that don't have primary care systems.
Yes.
And so it is for the people who they are seeing, who come through the doors, that they're accountable for under the hospital side.
Right. Yes, sir.
When you mentioned global budget, you talked about the existing setup that we have in terms of the hospitals.
Yes.
I'd like to hear a little bit about how you feel about systemic change in the service delivery part of the hospital. You mentioned a little bit about it, having clinics strategically located, keep them out of the ER, because that's one of the most costly parts of hospital healthcare. So how do you feel about that? Because I'm looking at this ahead program, and I'm looking 3-4 years out. To me, there's a crisis now. And these 4 hospitals are ready to go under. So why not do that systemic change rather than do a global budget on the existing structure that we have now? Change the structure of service delivery. Do it now instead of waiting.
Yes, and I actually think that's possible within, as I understand it, within the AHEAD model. The AHEAD model has the ability to, one, develops that community capacity, primary care, the support services, and I'm going to speak about that in a moment. And then in the process of the budget setting, you're setting the budget for these different hospitals, so to the extent you have concern not just about one big health system, but other ones, that's all in how the money is allocated. It is, whether the planning process can dictate, I guess this is what I would say, the planning process can dictate the priorities. So there certainly is the capacity to articulate the priorities that you're talking about, which, by the way, I support. I think to address the long-term issues that Elliot's talking about, you need stronger primary care in your communities.
I'll just make one technical distinction between the two systems. The hospital budgets are responsible for about half the costs. Oh, thank you. Hospitals are responsible for about half of the spending. We still have primary care, other community-based services, the physicians who are employed by the hospitals. And so one of the other distinctions is that under the ACO model or whatever the redesigned system, because I agree with your aspiration to create a better system, is do you want people accountable just for the facility-based spending? Or do you want people to take responsibility for improving the health and care of all of their patients.
That's, part of it is the prevention part of it.
Yes.
Yes.
Yes, absolutely.
So if you want better care for everybody, this model, which has for an aligned primary care population, people who are, and there are ACOs that are doing very well. They're very effective. They're just not implemented broadly. Let's come back to that because I want Chris to make sure he finishes.
I think
it's a great
hopefully
topic.
my comments get to some of that.
So there's one more question over here.
I'm sorry.
And I do have a question to talk about after all of this, and that is regarding our blueprint model and the work we're doing on 167 and ACOs together.
I got that.
I'm gonna hold that.
Chris will solve it.
I got it.
So are these-
Representative Houghton.
Thank you. Are these either or models, right? So do you do all, do you do one? And is there any data, and I think this has been asked a couple different ways, is there any data for each of them about access and quality? So everyone always talks about the savings, but access and quality is a real issue in our state. And to Representative McFaughn's point, what is gonna get us out of our crisis?
Well, I'm gonna go back with a question. How do you define the crisis?
The crisis is we have low access, quality is so-so, and really high costs.
Okay. So, and that's part of what I said at the beginning, you're broadening the challenge because you're putting access and quality in as well as the price.
Yes.
But you're the policymaker, so that's your prerogative.
That is my prerogative.
You define the problem. To your first question, I would think about these as developmental stages. Global budgets is a more complicated and more sophisticated approach to the same set of issues. I think it offers more potential, but what I really want to emphasize is you've got the tools in Vermont to do this because of the capacities you've granted the Green Mountain Care Board. These other states, Oregon, Washington, Montana, that are looking at reference-based pricing, they don't have combined insurance, health system oversight, insight into financials. So it frankly would be a distraction to stop at reference-based pricing. When you build a global budget, you're going to be incorporating some multiple of Medicare into it. So if you're asking for advice, this is the sort of, you're already there, frankly. You need to give some more direction. In terms of long-term outcomes to get a quality access, what the things that Elliot pointed to, it has to be built into this. You can't just say, well, reference-based pricing is just an incremental step where I want to do reference-based pricing to save some money, and I hope it doesn't hurt my quality or my access.
You hope.
You hope. And so far, the data is that it doesn't. But it's it is, Vermont has always been marked by the size of its health policy aspirations. And you've got this chassis with the Green Mountain Care Board. You want to build off of that.
Okay, thank you.
We have another question.
Feel free to punt this for later, broader discussion, but it's related to the access issue, and I might be putting you on the spot a little bit. You were earlier talking about economically rational behavior, and I'm speaking specifically about the Green Mountain Care Board asking hospitals to reduce the cost of their services, and my hospital taking that edict and focusing on net patient revenue and reducing net patient revenue, which is having the impact of closing badly needed primary care clinics, badly needed outpatient dialysis clinics, lowering and I'm experiencing this as a frontline worker, and others, clinicians that I've talked with are experiencing a forced reduction in census. Again, I think getting at lowering patient revenue and reducing reducing census when there's actual need, and, patients waiting to get in for care. It's not that, there aren't people out there that need access. So access is still the issue, that the hospital is,
Cutting the wrong, if you will, cutting in the wrong places. They're.
But this is an important question, and I think we probably should come back to it after your presentation and after our break, because it is one of the emergency pieces that's driving more change. Yes, and it's being played out in the media again, and it's something that's happened at the board level with budget decisions, not overall planning, not ongoing consideration for strategic planning and global budget, but there are decisions that are made within the budget process that then result in loss of services and patient access. So, so I'm thinking that this is one of the things that brings us right here, right now.
Right.
So.
I'll give what's going to be a really unsatisfying answer. What I would do if I were you is actually call colleagues in Maryland, and we can help you with that, because Maryland, if you think developmentally, Maryland's further down this path than you are, where they're trying to set and limit hospital revenues. That's really what our health system, let's call it health system revenues. And what happens when that results in undesired cuts in service, less desirable access? How does a Maryland setup respond to that and prevent that from happening? And I think it's a really important question. I'm sorry I don't have a really more than you just have to monitor access answer. And I think the place to learn is from Maryland. And also to learn what's the role of the legislature in that and what's the role of Maryland's oversight. Because Maryland has in place commissions to do this work. So.
And the Green Mountain Care Board.
Yeah, and they're the equivalent, and I'll talk about that, is the Green Mountain Care Board. Proceed?
Do you got more?
Yes, I'm sorry. Okay. A little bit more about global budget. It is more advanced, so you get direct alignment with Medicare and self-insured. It moves the hospitals from fee-for-service and makes rebalancing conceivable. So Maryland tells great stories. Once they were on a global budget, they stopped advertising their emergency room. They stopped advertising their radiology services. They started supporting children's obesity prevention in schools in their community, because they were still getting the same amount of money. They just didn't need it to come into the ER or their radiology. So it makes that sort of rebalancing really possible. It doesn't necessarily make it possible to build more aging services, stronger primary care. It depends, again, on what you put in the budget and hold them accountable for it. It also, by the way, is a guaranteed future for the hospital. You fight over the amount of money, but at least when I'm running a hospital, I know I'm going to get something. The cons, you could argue that what Green Mountain Care Board is doing is, well, they're certainly doing budgeting. What does it mean to change it to a global budget? Maybe it means moving it to a per capita basis. It's a really significant analytical lift. As I said, it doesn't build the capacity of community services. You have to tell Medicaid that they're part of the process so they can go off on their own. That's been some issue in Medicaid. It's really hard to maintain political will, because the first time the regulatory entity says no, they're going to come to you folks and say, fix it. Give me more. There is, look at what's playing out in the Green Mountain Care Board. My costs are my costs. I can't take anything out of that. And if you make me take costs, I'm going to kill the baby. Okay, and we've seen that play out. You want me to take costs? Do you really? I mean, I've been a policy.
We just heard about this.
I've been an executive branch person. I get orders for budget reductions from the governor, and I deliver the worst possible scenarios. I know how to play that game. So how do you? These problems are inherent in any kind of public budgeting process. So back to our barriers, and I've just got a couple more slides, a few more. How do you align policies between payers? ahead goes all the way there. Reference pricing is pretty easy because it goes with Medicare. Growth caps are even lighter. This gets to your question. How do we do reasonable, durable structures and processes for planning when the market doesn't work? You guys are in the position to learn from your efforts to do this with the Blueprint for Health and Green Mountain Healthcare Board. Green Mountain Care Board. You have much more learning, much more experience than most other states. So they are going to be coming to you, frankly, to learn from this. And what I would say is, I want to go back to the Blueprint for Health. Senator Lyons asked about this. I've been a longtime supporter of this because it is an explicit effort to strengthen our primary care capacity. And Vermont has a running start on this. You've got the Blueprint for Health. You have a very strong footprint of community health centers that are, frankly, you've got more community health center utilization than other places. And you've got the blueprint, and that blueprint model was really essential for you folks with opioid and COVID and now aging services. You do it for SASH. It was eclipsed by OneCare. The bet was that if we could create this accountable entity, they would invest in primary care by themselves and would build up primary care because it would be in their interests. If it's any consolation, the fact that it didn't happen in OneCare is the same thing in Medicare. What they found was that hospital-based accountable care organizations didn't reallocate. They just kind of played along with the game until Medicare gets tired and lets it go. But when you really have primary care organizations accountable for the whole thing, and I'm not saying tomorrow we should put all your health centers at risk for everything, it actually works. So I don't see global budget and strengthening primary care as either or. I don't even see accountable care in global budgets as either or. You just want to move slowly with your primary care and build them up over time. I would say, my observation, there are people who are closer, over time, the Vermont Blueprint for Health has lost its ability to put in significant additional money to set that policy and planning agenda. So it's become lower profile and has had, I'm not even talking about what its budget is in terms of allocation, but it has less authority to do that kind of planning function. So
do you have a suggestion? Maybe that's something we could pick up. It's a question that I have for you afterwards, so I can hold that thought about.
Yeah, well, and I think, I would think about your questions about Blueprint. This is Elliot's slide.
Yeah.
Back to a learning health system. This is not only a learning health system for UVM or any other health system itself, it's a learning system for Vermont.
Yes.
What have we done? What can we learn to do? And I think that evaluation and planning function is where you say, in this case, we want to strengthen primary care. We want to strengthen our community capacity. We want to put resources in there. And so the last piece that I got, or the next to last piece, is just, and I apologize, this is sort of big thinking. Why is this? There it is. It loaded. When the market, this is myself. If we can't rely on the market to allocate, who does this work of allocating? How do we do this in other places with public goods? And I looked at education and public utilities. This is very, very high level. It's worth oversimplification. Public utilities, we give it all to one thing, and we let them do it and deal with a regulated entity. That would be like creating an strengthening the authority of the Green Mountain Care Board. And you would hold them accountable for certain things. In education, we've got these locals. And so the state is raising money and sending it to the locals. They're setting some standards. We have no locals for health care. We got a bunch of health centers, we got a bunch of hospitals, so you have no kind of locally controlled entity that you can give to. On the rightmost in Maryland, I think that's a place you can learn from. Their evaluation and planning rests with the Maryland Healthcare Commission. It's not dispersed across a bunch of different agencies. So the Maryland Healthcare Commission says, we want to go big into primary care, or we want to go big into community services. They set that kind of priority. Here, as I understand it, it's dispersed across a bunch of agencies. So you have some planning happening in Green Mountain Care Board, some happening in Medicaid, Department of Health Access, the legislature. The implementation for providers is spread across everybody here, because that's, your Green Mountain Care Board is determining budgets, but DOH has some funding authority. Medicaid pays directly. Public employees is making their own decisions. Medicare, Maryland, it's still complicated, but there are a bit fewer. It's trying to get fewer moving parts. And then in terms of who interacts with the payers, it's the Green Mountain Care Board of Vermont, Connect, your exchange. That's a lot better than some other places where they don't have that centralized authority. Maryland, they have their insurance regulators. And then you have this measurement and monitoring, what's going on real time. So this is a lot. I just think it's something, it's really important for policymakers to think about this as well as what's the right payment method? Or do we want to advance primary care? It's how do we do this work? How do we have this kind of learning health system that Elliot was talking about? I'm just going to race through this and we get the conversation. I circled this just to point to the complexity. I think that's your point of comparison, and there's a lot to learn from Maryland. And your challenges are defining your priority problem. Is it affordability or is it accessibility and quality? And the problem of cost reduction is hard. You got to say no to people. How do you do that? Or can you give it, how do you strengthen the Green Mountain Care Board's ability to do that? And then how do we learn from your grand experiment with the Green Mountain Care Board, which I encourage you to think about it in a learning way as opposed to a failure. We've been doing it, we're learning some stuff, let's make some improvements. Don't, I guess, throw the baby out with the bathwater. I think you need alignment with Medicare. My own opinion is that a head is too good to pass up if you know what you want. But you need resources for that health system and planning function. Whether you have to decide as the legislature, is that in Green Mountain Care Board or is it someplace else? I think you need an explicit strategy as part of that planning for health system rebalancing. And to Senator Lyons' question, you got to think about how you hold how you bring them here. What is it that you hold them for? I don't think, my own opinion, you say go do reference-based pricing. But you do say, what are you, on a regular basis, what are you doing, why, and what are your results? So that that's the accountability. And you've got the power of the purse. Last thing, this is just me personally, I'm a big Vermont fan. I'm a fanboy. You know, whether in Mount Mansfield, Lake Champlain, or Upper Valley, you know, if I can convince my wife, we'd move up here. But we're big fans of what you're doing.
You need more taxpayers.
Yeah, you need more taxpayers, right?
You're welcome to join us.
Yeah. So keep up the good work, and both for myself and for Millbank, we look forward to helping you with this going forward.
Well, thank you for that, and I do have, I've got questions, and I think others have questions. But I think it would be helpful for us to take a break. And then we're going to come back, and I'm going to invite the Green Mountain Care Board and folks from Brendan and David, and I see that Owen Foster has come in and Jessica Holmes. They'll all want to come up together and we can have a conversation around the table asking questions. That's one of the things that I like to do in my committee, and I think it's really healthy to do that. I have some difficult questions to ask, not difficult for you to answer, probably as much as difficult for some of the folks in the room and how the problem is playing out. So let's take a break.
How long?
Is that good for everyone?
What time are we back?
Let's come back at 11:05. That's from Representative Black. We're on it. 11:05. All right, so we are back. This is a joint meeting with Senate Health and Welfare and House Health Care. And we have had some presentation of some really important and helpful information from the Millbank Foundation and from Elliot Fisher of Dartmouth, and we're very appreciative of that. But we also have with us members of the Green Mountain Care Board and the Healthcare Reform Director from AHS. And I think we have questions about what we've heard and the best way to go forward. So I have lots of questions, but I would like, if folks around the table would have questions, write them down, get ready to ask. I would like to start with the concept of the relationship of hospitals to our primary care. And I know that's something very important, and you brought up the blueprint. But how can we enhance one and keep the other? How can we not, damage our hospitals and keep our hospitals financially sustainable, and at the same time reinforce and build our blueprint for health, primary care? So thoughts on that, and I know it's just sort of an instantaneous question that you may or may not have thought about. I'm sure you have thought about it, but any thinking there, just to start with that. That's one. And then the other question that I'd like to think about for all of us is, we've been putting in place some regulatory principles for the board. Okay, so suppose it's a global budget, and suppose it's the per capita budget that folks have been talking about. Could be a CPI, could be any one of those, but it will be something. It could be something that helps to reduce the overall expenditures over time. How do we hold, where is the accountability in that? And who's responsible for overseeing that things actually happen? So that's my second question. I'll save my third. Just general questions. Do they resonate with you or not? If they don't resonate, just speak up and your response to what you've heard today or further information.
Why don't we introduce ourselves real briefly? So I know they already did. Owen Foster, I'm the chair of the Green Mountain Care Board. Dr. Merman and I started the same day, October 1st, 2022. And,
I'm Brendan Krause, the Director of Healthcare Reform at the Agency of Human Services, and I started in July of 2024.
And I'm David Merman, Green Mountain Care Board member, started at the same time as Owen. And I just, as the chair is I would say beyond a full-time job, I have another position as well. I work as an emergency physician at CDMC. And I think that, just want to mention that, I think it brings some of my perspective to to a lot of this work.
So I'll start with the primary care question. I was excited to see the mention of the blueprint, and one of the things that we've been pretty actively thinking about and talking about in committee with all of you actually, is how we can better leverage the blueprint as sort of this blueprint 2.0 concept that you had, Chris. We very much see the blueprint as, was most famously known for its primary care medical home model. It's also very much potentially an engine for delivery system transformation. And you can see that in some recent expansions that have occurred in mental health, embedding mental health in the primary care medical home model. So we very much see the blueprint and the Vermont Chronic Care Initiative and their related field services as a platform upon which we can build and tie into the transformation agenda, primary care integration into the model.
On the primary care and the relationship with hospitals in Vermont have a lot of the primary care in the state. We're trying to support primary care everywhere. We're agnostic as to where it is. There's a lot of benefits to having it at FQHCs or independents. They're often more affordable for those services. And they also send referrals to any number of different places, whereas often you'll have hospital referrals from primary care to hospitals, which may be more expensive. But nonetheless, our view is that we need primary care as much as we possibly can. And the board has taken a lot of steps to look at productivity and operations where we can improve our access to primary care. UVM Health Network has done a lot of work, they're the medical center rather, recently on improving access to primary care, which we think will start to pay dividends in the next couple of years.
I'll take a shot at the primary care piece because we've been working on this a lot, both at Millbank and in my prior life, and that's where I interacted with the Blueprint for Health a lot. I think two things, a reality around primary care besides the numbers and the difficulty of the work is that a significant number of primary care clinicians, I don't know what the number is in Vermont, are employed by the health system. So when we think about strengthening primary care and building out primary care, how do we do that in the context of an employed relationship with a larger health system. And I think two things that are in the blueprint bones originally that are worth holding on to. One is a community-based approach to strengthening primary care. So a hallmark of the blueprint has been when we gather folks, when folks are gathered around primary care, they're done in the context of some sort of geographic catchment area. So we're working with all the primary care providers in St. Johnsbury or in Rutland, or as many as we can possibly get. We're not relying on the health system or the employers to convene them. So that allows you to keep the focus on the community and the social determinants of health. It also breaks down some of the barriers. The other thing, which is harder, so that has to be supported somehow. Department of Health, you need people who are going out and meeting with them and feeding information and producing the data to say, here's what's going on. The other thing that I think is even more important is the flow of money. You have to think, you not only have to provide money to hire an extra care management nurse or some little piece, do some training. You have to think about how the money flows to the practice, preferably attached to a patient. And that's really what Blueprint worked on. And it's a real challenge when half of your, it's not so much a challenge with health centers because they're used to be held accountable, but when you have a health system that's employing primary care docs in a bunch of different places, especially if they're geographically diverse, how do you make sure that money actually goes to build primary care capacity, especially when you're paying it to the health system? And that's no knock on the health system, but in a number of states, they're telling payers, look, increase the money that's going to primary care. And the payers pay the health system, and no one knows if the money is actually making it out to the primary care docs. And I think that's something to think about as you do it. And it is possible, but you need some state oversight to make it work.
When you say health system, you are thinking about where's that money going?
Yeah, you're thinking about the I'll do Rhode Island because that's what I'm familiar with. Half the docs there are employed by health systems, meaning what we used to call hospitals.
Okay.
So I'm cutting a check, or I'm telling the payer, go cut a check to benefit primary care.
Yeah.
It's going to the health system, and then I run into the primary care doc in the grocery store, and she says, my life's miserable. I'm not seeing any of that money.
You're actually getting to a place, I think, where there are a lot of questions about how do you follow the money within that system.
Right.
So and I'm looking at the board, the questions about that in terms of Oliver Wyman report said a single audit, a single way of looking at folks, and we've seen recently the disagreement out in the media about UVM Health Network, UVM Medical Center, and how is the money followed? How would it be followed, or what are your suggestions from the board perspective?
So there's different money. This has come up as a regulatory issue for the board in the context of the ACO. There's population health management payments from the ACO out to hospitals and to support primary care. And that was exactly something that we looked at, which was what Chris is touching on. When the check went from the ACO back to the hospital, did the money at the hospital get to the primary care providers? Did it go to support primary care? The truth is we weren't able to get that level of granularity, and we required it as a board condition to certify that the money was actually getting to primary care. And there was some starts and stops in the information as to whether or not it actually was. But then outside of the ACO context, you just have regular rate increases, and that is something that we do not go that granular. We give a hospital a budget, a rate increase, and how they allocate it is within the hospital's purview. But in Vermont, many hospitals have pretty good discretion as to how much money they go up or down on rates, right? So historically, you've seen a hospital say, okay, we want to go up 20% on this service and down 2 here, or up 5 here and flat here. It's not like when we give a rate increase of 5%, it goes across the board. And so that is something to think about when a hospital is allocating its rate increase that it gets and its commercial prices. Where is it putting it, and is it flowing through to what we're trying to drive at as a state, including primary care?
And I would say that in Blueprint is a little different because those payments are tied to specific initiatives and issued by the Department of Vermont Health like it says. So it's a little bit cleaner for us, but that's obviously not systemic as the chair was saying in terms of hospitals ACOs. Systemic adds to the blueprint.
Yes,
but
it
not-
does. I mean, everything makes sense here. So I want to turn to Representative Cordes' question earlier about what's happening, and we'll come back to your question, Representative Rebecca. But your question earlier about what we're seeing in terms of budget decisions being made and then affecting causing a reduction in services. Do you want to read?
Yeah, before you go in the room, I had asked about, a comment was made earlier about the economically rational decisions that, I'm speaking about my own hospital, UVM Medical Center, made to the Green Mountain Care Board request to, or edict to lower cost. And then what the steps that happened after that with the hospital focusing on that patient revenue, which translates into the hospital cutting census. Not because there is less need on my unit, the cardiology unit, there's still people waiting to get in to receive cardiology, inpatient cardiology care. The arbitrary reduction in census is causing a backup of people waiting to get in for care. And then, of course, the primary care practices and the potential loss of the outpatient dialysis clinics, which has been an issue for the hospital for many years since they first tried to sell to Fresenius.
Okay.
So it feels like another squeezing the balloon problem. But I am concerned about that kind of response because it's not, it's reducing access to critically needed services. And so I do support however we do it, more of a unified system or approach where we can get the folks that need to be at the table making really hard decisions. I was joking earlier that maybe we'll know we've succeeded when everyone's mad at us.
Some thoughts in response, and how do we get there? Yes.
I think you start this one. Come back to primary care.
Short question.
This is your world.
I think, so the concern is really that if there's a cost containment effort, it is the result of the cost containment effort to lose services, and what services are we losing? So I can speak to our enforcement order that goes to this, which discusses why and how it was done. And what we look at and consider is, do you need to cut services in response to this cost containment effort? And the answer to that could theoretically be yes, but that would presume, one, that you don't have the money to withstand the losses, two, that you're operationally highly efficient, three, your clinical productivity is very high level, and four, that you have reasonable prices. And when we made our decision, as discussed in the enforcement order, we saw a number of opportunities to improve aside from cutting services. And we laid those out. Now, when we don't have control over what services are specifically cut, it's not it wasn't part of this budget process. We might be looking at it in the future as to whether or not we can. But we saw really significant financial gains year over year. And we saw some monies owed, and we saw some productivity that could be improved, operational excellence could be improved, and we felt that those could be addressed first, and that's not where it went, but that's what we do in our orders. We say why we think that this reduction is appropriate. I hope, does that answer?
In a reduction in cost of services, a reduction in the cost of some services is also.
Correct. So prices, commercial prices. There's some metrics we look at, national data we look at, and if a hospital had very low commercial prices, is it appropriate to reduce their price request? I would say in this environment, that's a hard decision to do. If the prices are very high, already very, very high, it's a different conversation. And then you do look at what are the assets available to cover losses. And if the assets are $1.3 billion, can you withstand a $2 or $3 or $4 or $5 million loss on a service that's important to population health in the community? My general opinion would be, in the short term, yes. In the long term, that might not be a sustainable path. But we look at the financial health of organizations at large in making these considerations.
Thank you. So we've had Representative Black, Representative Rebecca, and then Representative Houghton. So we've got everyone on deck, and as you have a question, just let us know.
Could I add one quote of that, if you don't mind? So,
yes, sure.
Also, as we work together on transformation, these decisions have to be thought of in the context of the whole system as a whole, right? So if you have sufficient mental health access elsewhere in the state, maybe that's not suggesting it's not, I don't know the answer to that question. But you have to think about it together with the broader role.
Thank you. That suggests a statewide health plan of some kind, isn't it?
So in light of many of the things that we've heard from all of you, it seems as though when you look at past efforts at transformation, particularly around primary care, because we know we have a crisis of primary care in the state, it feels as though we've incentivized hospitals to sort of expand primary care. And as Chair Foster has just pointed out, we know that primary care in the setting of a health system, a hospital health system, it's more expensive. It tends to have, I believe, with our all-payer model, lower quality outcomes, limited access. What levers do we have as a state to incentivize the removal of primary care from hospital health systems? You just talked about with the ACO, the incentives, and we don't even know when it's paid to a hospital health system whether that money is going to expand primary care. The blueprint community health teams are administered by the health systems, and oftentimes the community health team member is employed by the health system. Is that the most efficient use of our dollars? To your point of providers being employed by health systems, I think one of the things that we also know is that it's easier to be employed by a health system because frankly, the administration of running your own practice is, I've never met a doctor who went to med school so that they could, deal with healthcare financing. What can we as a state do to incentivize the removal of primary care from hospital systems, grow our primary care workforce, and also support primary care in the business of running practices? Does anyone have any thoughts around that?
I could start on that. I think that, as you point out, primary care that's delivered outside of a hospital system tends to be far more cost effective. It's less expensive for commercial insurance, Medicare. I don't know exactly the Medicaid payment in Vermont. So I think expanding and supporting primary care outside hospitals is really important. What I wanted to mention before, and I think how to do that, I think is complicated, and I have some ideas that are sort of just, the ideas of one board member ideas and not, things that I think we have worked out as a board.
Definitely have you to testify.
We're looking for ideas.
But I lost my train of thought of what I was going to say about hospital primary care from before. I think that, yes, it's far more cost effective to do this outside of a hospital-based system, and the supports that we need to do that are important. As we talked about before, the hospital primary care relationship, our hospitals are really dependent upon the primary care services that are delivered outside the hospital. Community Health Centers of Burlington, I think, is a really good example. if community health centers in Burlington were to were to implode, let's say, UVM Medical Center would be completely overwhelmed. So the service, they are interreliant on each other, but the FQHCs are largely across the state are very financially struggling right now, and they have solvency issues as well. So, I think actually the healthcare transformation team would probably be better to speak to how you can directly fund those practices, but I think my focus would be on expanding what's available as opposed to removing from a hospital entity. I think that they actually, while more expensive, there are a lot of good integrations they can do.
So while you're on that topic, the governor's budget includes millions of dollars that will theoretically go to FQHCs. I see that as transitory, stopgap, and not anything that can continue. And so I'm not asking a question, I'm stating it from an appropriations perspective. We can't do that. We can't pay every hospital and every FQHC to stay alive. I mean, it is important, but your comment about the FQHCs, and in particular the Burlington, because that's where I am, that's where my, it's not in my district, it's in Senator Gulick's district, but it is critical to keep them alive and to ensure that the money that's going there is sufficient to keep them alive. But I didn't want to co-opt other folks who have questions to ask.
Might I just ask a question to my colleagues? It does seem that having the data about where the primary care money funds are flowing and through what elements of the hospitals or however, I don't know whether they all have defined corporate entities that within which the physicians are billing. Often they're billing under a medical group, even though the money gets paid back. But I would be really curious to understand what the structures of the hospital primary care system, hospital associated primary care delivery systems are, where the money's flowing, and then think about creating a unified view of primary care funding and assets and resources across the state to support the transformation planning, because we need that foundation. And it seems like the black box of the hospital's delivery of primary care keeps us from being able to do that kind of thinking.
And if I may, that gets to Elliot's, in his presentation, that planning and evaluation function. So if community-based primary care is a priority, what Elliot's asking is, well, what do you have right now? How do we know so that we can measure it and how it changes? And that means, in addition, to bailing out financially distressed providers, we have to have the ability to measure so that we know if we're making improvements in it over time.
And I think it actually goes beyond primary care. I think, and Elliot and I were talking about this earlier this week, I think if you look at Vermont's experience with an ACO versus other states that have more successfully sustainable ACOs in terms of quality and cost savings, we don't really have a lot of non-hospital-based specialty care. We don't have a lot of places to do that care coordination that's not in otherwise it should be an inpatient setting with the fixed costs associated. So, I think that there is an opportunity, and, sort of looking back at FQHCs, we're lucky we have maybe struggling, but a robust infrastructure of FQHCs that look more like multi-specialty group practice than anything else in the state, from my perspective. Are there ways to build sort of the good parts of ACO theory and tactics in terms of analytics and administrative streamlining and funding, around those institutions that would positively incentivize care moving to the community?
Just a friendly amendment, we have to change the name in Vermont.
Oh.
Population Health Organization.
Yes, oh, right, that's what you called it, okay, yeah, that's it.
Okay. We're going to move on to Representative Rebecca, and then we'll go to Representative Houghton and Representative Chena. So Representative Rebecca, you're on.
I think it's a good time to transition. I thought you were referring to changing the name of the CCBHCs like you did in Vermont. I'm wondering if anybody can help me understand, in all of this discussion of payment reform and hospital transformation, where does mental health fit in? Because I find it hard to believe that we can talk about payment reform and not be talking about
quality, which has a huge impact on affordability, right? We're not talking about caring for people in this conversation at all. We're not talking about the fact that, you know, we can't really be addressing the ability or the accessibility to services while not truly talking about addressing the demand. And I think if we're not talking about how people come into hospitals, including the people who shouldn't be there, you know, we're not really gonna close the nozzle on affordability of hospital care. So can someone tell me where mental health fits in and substance use disorder care fits in? I know the blueprint is one option, but the blueprint's been around for a while and it's clearly not reaching everyone who needs it.
I can just quickly say, you know, in the context of payment reform, that's one of the explicit goals of the head should, you know, that actually, you know, take effect and and the state get access to the additional flexible funds. One of the highest priorities will be improving and expanding access to mental health and substance use. So it's very much on the roadmap, but others could. Yeah.
I just made 2 comments. First, if I look at what Intermountain or other systems, and I think we'll hear more about it, they really are trying to think about the population they're serving, you know, just the way an FQH is, who are the people who are responsible for and how do we meet their needs? I think the model that has been proven very successful for behavioral and mental health services is their integration in primary care. And I think one of the things that has not been thought through sufficiently, and maybe you did it in Rhode Island, I'm unaware of it, but how to make sure that what, you know, primary care and mental health care, you know, basic community-based mental health care services are delivered. And I put those in the bucket of primary care. And I don't know what that number, you know, people have been talking about an 11% target instead of 5% target for primary care funding, but it should include, I would include in the target, and I see Brendan nodding, you know, what's the budget for great primary care and behavioral health, necessary behavioral health services? I would mention that severe mental illness, I kind of put in, I think people should think differently about because that's such a different level of service that's needed. But
did that factor into any of your, you know, consideration when you're talking about, you know, transformation of Vermont's system?
Perhaps not today as explicitly, but I think strengthening primary care has to be done in parallel with how you're redesigning the hospitals. Because we can have much smaller hospitals if we got primary care right-sized and kept people out of it.
And a way to think about that, this might be what you're saying, is the definition of primary care is called comprehensive or advanced primary care, and that includes the ability to treat low acuity behavioral health with integrated behavioral health care. And that's the blueprint as conceived it's an ongoing process to try to create more comprehensive primary care. And so what I heard in your question is some concern that maybe the blueprint hasn't done that for behavioral health. Then we have to think about the program. I'm not sure it's legislative action, but that's what's in that definition of comprehensive primary care does include behavioral health and how do we improve the capacity of these primary care folks to provide it. The other, since I got the talking stick, I just want to note, really, since we've been talking about primary care, primary care is a relationship between the family and the caregiving team. Mm-hmm. In public health, which struggles with this being kind of moralistic, they use the language, how do we make the right choice the easy choice? So if the right choice is for folks to have primary care, how do we make it the easy choice? That gets to questions of benefit design, maybe how do you create financial incentives for people to use it? All that is part of, if you want to have a less institutionally based, specially based, we've got to make the right choice the easy choice. It means looking at scope of practice to make sure that everyone's practicing at the top of their scope. It means measuring. So it means looking at benefit design as part of what gets built. So I found that relationship thinking about primary care's relationship to be really helpful. So how do we, and relationships are a two-way street. So we gotta get people to commit to, we gotta make primary care available. We gotta get people to commit to it.
Thank you. Well, I'm sure that both our committees will be continuing discussion on mental health issues and obviously the hub and spoke that's been going forward and the integration of community services with social and medical integration has become so critical, is critical. I'm going to go to Representative Hill.
So thank you all for this. It's fabulous information, a lot we have to dig into. And it's charting a long-term course for us to continue with transformation. And quite frankly, I'm really worried about the crisis we're in today. I'm gonna go back to that. High costs, access issues, teetering on quality issues, not being able to track those very well. We can do reference-based pricing, we can do global budgets. That's capping a system that we know, is trending, their financials are trending down. It's not helping us move money into the community supports where it is cheaper. And we can, so there's, I just feel like we're coming up with these long-term solutions that in the short term will create bubbles like we've talked about. And we are in a crisis today. And as Dr. Merman said, if we have an FQHC that goes out in Burlington, UVMMC is in dire straits. If we have health insurance companies that can no longer function in the state of Vermont, what do we do? So I'm looking to all of you very smart people who have a lot of history to help guide us in the today as we plan for the future.
COVID.
Okay, so you just asked a great question. You left in silence.
And I mean, there might not be an answer, but I think that's what needs to be on.
Oh, no, we have an answer.
We learned a lot in COVID.
Yeah.
About emergency planning. You pull teams together that are diverse, that have the various players who could make a difference, whether it's in the executive branch, the hospitals, the community clinics, and you say, we don't know what's going to happen with the federal government. We can't have prices go up like this. And what if and let's just start, Vermont was a great model. I love listening to the press, to the morning press conference, the governor's press conferences. I'm just thinking, you take an emergency planning model, or a short-term planning model. Maybe it's not an emergency, but we try to say, what could the board do in this next budget cycle to help slow cost growth? What could the blueprint of the governor's office do to strengthen primary care? And where are the emergencies? If we wait to gather the data from my wished-for planning agency, it's going to be too late. What data could we have now from each of the FQHCs to know their balance sheets and days cash on hand and figure out who's really the emergency that we need to? So I think of the COVID model. Even though the time frame might be longer, but if they decide to unfund Medicaid, we'll have that model on our hands sooner than we wish.
I can speak to some of the things we are doing currently every day because of this crisis. So one, in the last several years, we've been trying to get a lot more information about the broader system. So I can tell you how many days cash on hand Howard Center has, Little Rivers, community health centers. And the board has informed itself, has put in a lot of effort to be more aware of the broader system as opposed to the one we regulate, which is the hospital system. Because when you make those decisions in a silo, you don't make the best decisions for the system. Okay, we've done that, and now we're taking different actions with our regulatory decisions, acknowledging this issue. There's a lot of reserves in the system, actually. It's just that they're concentrated in certain pockets, and they're not really being utilized to sustain the entire system. So if we look at some of the board's decisions recently, we've really reduced the commercial rate increase for hospitals significantly. I think system-wide it was 3-4% last year. The year before that it was, 8, 9, 10%, something like that. So we've reduced that. That will make it more difficult on hospitals, there's no question. But the upside of that is some of those FQHCs and some of the primary care that's independent was able to get larger rate increases than they ever had before. So we've balanced it out a little bit where the broader system around hospitals can survive a little bit better. Then you talk about Blue Cross's solvency. This is a domino. You lose any of these things and it's a domino on the system. So we're acting in a crisis situation in our decisions. We gave Blue Cross a very large rate increase last year, recognizing that if it had a bit of a problem paying claims, everyone was in trouble. And then the other thing we've looked at is, the enforcement decisions that Representative Cordes asked about. Well, that was a painful decision. It was really hard on UVM, but it helped stabilize and support Blue Cross's ongoing concern, and it helped create money and available money to pay others better. So it's just, we are trying to, in every decision, balance this sustainability of everything, and it's very, very difficult without any more money to access, and there's pain when you do it in certain sectors.
And I think, I'm sorry. And I was going to say similarly, there are a lot of activities that the HHS teams and the departments are doing every day that, I might not mention as often as I should, but, they're also, daily monitoring sort of these access and cost issues, convening with FQHCs. It's other activities like, some of which were on the late slides, but, working with the hospitals to improve transfers of bed blocking, patients who are bed blocking in, say, UVM. When there's capacity in other hospitals, that would be a win-win for the system. That's very short-term, but very tangible and very cost-effective. Similarly, reduction in ED utilization through some expansion of some community-based interventions, for example, the recent mental health expansions, et cetera. So I do really think that and then they're sort of I think probably where we're all going to start is looking at those administrative costs across the board in terms of, sort of high value, low cost, rate reduction. Cost reduction. So I think there are things we can do fast while we plan.
And may I just follow up? Just
Quickly.
And so
one more.
I appreciate all of that. And I know it's hard work, and I want to make sure everyone has what they need to be able to succeed. And I will say, I like Elliot's suggestion that we go back to our COVID mode and we start doing some emergency planning. As smart leaders, trying to find a solution to get us through this crisis, who knows what else will be coming our way, and ensure we have the system here as we transform it into the best that will bring more people into Vermont.
Point well taken. And I will say that we will be looking at a committee bill that will include some of what you've just said in terms of what can we do in the short term, an emergency, and then moving forward. And you folks are going to improve it when it gets over to you. But Representative Chena has a question.
You have two questions. The first one is probably the easier one. It has to do with spending on primary care. Several years ago, before the pandemic, Rhode Island was doing work on shifting spending towards primary care from the hospitals, and I was doing some internet research waiting for the question to look at where they're at. And I'm not going to report to everyone what I saw, but it looks like they had a problem during COVID and now they're getting spending under control again. So I'm curious if there's any lessons for us to learn from Rhode Island or other states around how to shift the spending towards primary care, since that could help the long-term population health outcomes and save money in the long term. But then similar to the question you just heard about an emergency, I guess the question is, at what point do we recognize that there's a public health emergency again? Like we're seeing with unsheltered homelessness in Vermont, a burden on the healthcare system, and we're seeing diseases spreading again, like new forms of COVID, potentially an avian flu outbreak coming. Like if we are not prepared for that, so I guess the question is, at what point do we declare a state of emergency and use the Medical Reserve Corps again to fill in the gaps, and use the National Guard to step in and help address some of the issues? And that could alleviate some pressure on the system as a whole while we then fix the problem. And so I don't know, those are just two things we could do in a state of emergency, but there's many others. Like I saw in 2 days us change all the regulations and rules. Like we passed a few emergency healthcare bills in like 2 days that affected things from provider taxes to to other kinds of regulations that I don't need to like repeat. So I guess just putting that out there, number one would be, at what point do we declare a state of emergency, and what might be the things that we could do in a state of emergency? What might be the resources we use to take pressure off the system while we fix the system? And the second piece would be, what role would reinvestment in primary care play? If that makes, just to rephrase.
Good, and what we're going to do is we're going to let them respond to that because we need to finish at 5 of and no later. I want to just bring closure to the meeting because I know that Chris Kohler has a meeting he has to get to and need at least 5 minutes between now and then, I get it.
Can I take a shot at, thank you for your primary care spend question, because that's that's my baby. I think they might put it on my gravestone, because we came up with it in Rhode Island. We landed on primary care spend as a concrete, easily understandable way to focus on the need to build community infrastructure. What portion of the dollars are going to primary care? And there are comparisons with other countries and high-performing health systems. You're asked to your point about what are the lessons from Rhode Island? Persistence. So I'm not aware that that primary care spend in Vermont is one of the key indicators that Vermont Health Access or Green Mountain Healthcare Board is measuring on a regular basis and then holding people accountable, holding entities accountable for. So Elliot was talking about quality improvement gurus. You improve what you measure. And so and I would argue that primary care spend continues to be it's a measure of progress. It's also a way to focus people's attention because most people think we spend a lot more than what we do on primary care. Rhode Island has made some measurement tweaks over time. How do we, what's in the numerator, what's in the denominator, how do we deal with people who are getting their care out of state and stuff like that. But the big thing is you just gotta stay on it. You gotta keep at the top of your list. And it's actually pretty easy to do if you can remember to keep doing it. So it is, and first you measure and then you set targets for what it should be. I think you hold health plans and the payers accountable for it, but you can also hold the health systems themselves, get past the payers into the health systems. But it's the high-performing Medicare ACOs, they're all spending a ton on primary care, way more than what everyone else is doing. So I think you just got to stay focused on it.
Okay. Thank you.
I'm not going to do the public health emergency.
We won't, the emergency piece is something for us to consider around the table, and how we do it is going to be.
It could also be air quotes emergency.
Yes.
Well, maybe the thing is, what did we measure during COVID? How do we know we were making progress? It was ER visits, it was vaccination rates.
Right.
I'm sorry that the rep is left, but what are our key, if this is a crisis, what are our key measures? What do we want to see improvement on?
Cost, quality, access, how do you do it?
So
exactly. You have 1 minute, Representative.
Since we brought up COVID, one of the reasons we were so successful here is because the federal government stepped in with a lot of money.
Don't lose that Medicaid right now. Keep your eye on it. That would be one of the key indicators.
Medicaid is.
To your point, sir.
Yeah.
So we won't go there right now. We're all apprehensive about what is going to happen at the federal level. Understood completely. And we have to focus on what we can do here to improve the system in Vermont, and then we will also be keeping an eye at the federal level, and work to do what we can do there as that happens, when it happens, and we'll be there. Good question. So I just want to say thank you to both committees. It's been very helpful. I think it's been helpful. You folks have been more than helpful, and can't tell you how much we appreciate your sharing your wisdom with us. This isn't the end of it. As I said before, our committee will begin a bill. We're working on, I put together some stuff, and everyone who's in the room has helped me inform that. And then we'll be reaching out to each of you again for help. Because we are in a crisis, we said that in the beginning, and we know that we need to act with alacrity and with alignment. So So thank you. Well, we're going to adjourn for the day.